clinical duties. We do not publish these or use these in any other way. If you have any reason that you do not want to participate, excuse me, in a recorded event, we invite you to leave now, but your staying with us implies your permission to be part of a recorded event. This program tonight provides 1 hour of Category 1 AMA CME credit for physicians and 1 hour CE credit from the Virginia Nurses Association for nurses, including nurse practitioners. Sovah Health is accredited for physician CME by the Southern States CME Collaborative. Our program is accredited by the Virginia Nurses Association as a commission on accreditation for nursing CE credit. We have developed this program to try to promote three what are known as desirable physician attributes that include interpersonal and communication skills, our providing patient-centered care, and our working in interdisciplinary teams. Neither Ms. Sturdivant or Ms. Bivens-Pippin, myself, or members of the CME committee at Sovah Health have any commercial relationships to disclose to you. There is no commercial support for this program this evening. This program, like all of our programs, are supported by an educational grant from the Ralph Landis Medical Education Fund that resides at the Danville Community College Foundation's Educational Foundation. Dr. Landis, who founded the local urologic clinic upon his retirement, generously donated a significant amount of money to what then was the hospital's foundation to create enduring support for medical education for all types of healthcare professionals. This fund was subsequently placed at the DCC Educational Foundation, where it continues to support programs for not only physicians, but nurses, nurse practitioners, nursing assistants, dentists, EMTs, and many other healthcare professionals in our area. We have a new way that you can do your evaluations. Mary Kent, with her excellent skills, has included now a QR code that you can click on if you so wish to access the eval form. This will appear in the chat box at the conclusion of the program this evening. In addition, this evening or in the morning, we will be emailing to you the traditional evaluation form. Please use whichever option you prefer to access that eval form. I would remind everyone that when you get the eval form by either method, it will ask you to again re-register yourself into that form, meaning name and your email address. Please put your full name in that registration. Don't give us a nickname or a short name, in as much as this is what will be on your CME certificate. If someone is with you this evening participating in the program, which we're delighted to have them do so, please let Mary or myself or Van Holt know this so we can be sure that everyone who's on the program eventually gets a CME certificate. We'd like to remind our many residents that are on the call that your CME participation this evening, as is required by your residency program, is tracked by your coordinator. That's Daryl Johnson and Lori Galvez. So you don't have to keep up with certificates. Otherwise, the CME certificate will be sent to you electronically through once you send the eval form in. I make the point that each time we talk about this, that nurses and nurse practitioners must submit an eval form to receive a CME certificate. That's a requirement by the Virginia Nurses Association. However, for the remainder of us, you do not have to necessarily fill out an eval form if you choose not to do that. We're sorry you don't. It's very helpful to us. You just need to let us know about that, and Mary's aware of that. Each time we gather, I also like to particularly thank Mary Kent, who's our CME coordinator, and Vandora Holt, who is the nursing director for the Market of Education. Both of these ladies make these programs possible. They actually do what would be called the heavy lifting in the back room that makes it happen, and I'm very grateful for their support and friendship. We encourage questions, and tonight I know our speaker is going to encourage questions And not only that, but comments and your insight into the topics that she's talking to you about. When you ask a question, please identify yourself. Tell us what your area of healthcare profession is. It makes the conversation a little more personal. And once you've asked your question, please mute your phone so we don't all get feedback. You're welcome to have more than one question, more than one comment, but if you will mute while the speaker's responding or Leslie's responding, it just makes the program a little more enjoyable. I want to remind you of some upcoming programs as we look towards the new year. First of all, Mary, Van, and I want to wish you the very best of all the holiday season that's cranking up. It's sort of cranked up at Halloween, but it's in full blossom right now with houses decorated, etc., and people planning family trips. We hope there will be a safe and time for you for that period of time. To that end, we are not having any CME programs in December. This is a time where most people are engaged with family and friend activities, and it's a time that allows us to complete a lot of year-end material work that we have to do for the CME program. I want to hope you will come back and be with us in January. We will be doing infectious disease programming in January. There will be 2 evening programs that month. Each of these programs will have 2 speakers. The first on January 9th will be an annual report on the DASON program. That's the the Duke Antimicrobial Resistance Surveillance Program. And it will review the changes in antibiotic resistance that we have documented at Sovah Health on the 2 campuses with the help of the good folks at Duke University Medical Center. And the second talk will be over the past 18 months, the newer antibiotics and antiviral drugs that are currently being used and how one uses those to the best extent. Then the second talk will be a review of antibiotic stewardship in the outpatient setting. So let me just highlight, this isn't the same old, if you will, antibiotic stewardship lectures you've heard before. They were all, by and large, hospital-centric. This will be specific regarding clinic-based patient care, emergency room-based patient care, and people leaving the hospital and how they are continually treated at home for infectious processes. And then the second talk is something that we are really fairly excited about. We're going to have someone from the Virginia Department of Public Health talk with us about those diseases that are reportable and what happens to the patient and their family when that occurs. This is a very unique opportunity. Personally, I was never taught this as I came through medical school and residencies, and it's something that I think will be a help to anyone that sees patients on a daily basis. That being said, we're delighted this evening to have what is the last in this year's series of diversity, equality, and inclusion programs. I'm delighted tonight to have Ms. Leslie Sturdivant, whom I hope most of you already know. Leslie is our Market Vice President for Support Services and Engagement. She is also a member of the LifePoint DEI and Belonging Council, which is a distinct honor for her being selected to help direct LifePoint's, if you will, system nationwide efforts to promote DEI so that we can actually provide better care in better ways to get better patient outcomes. So Leslie, I appreciate you doing this. Leslie's going to look after the program, moderate it. I'm going to drop off, take my slides down, and our speaker can bring her slides up. And Leslie, thank you so much.
Thank you, Dr. Moore, and thank each of you for joining tonight. On behalf of the Sovah Health Diversity, Equity, Inclusion, and Belonging team, I really want to thank Dr. Moore and Mary Kent for just the wonderful work they've done all year long with our CME program, but especially for helping our DEI team host quarterly health equity CME programs this year. And I got to tell you that no one does it better than the 2 of them, and we really appreciate them more than words can say. With that said, here at Sovah Health, we are on a very intentional journey of creating places where patients choose to come for healthcare, and it is a choice, where our physicians and providers want to take care of patients, where they feel like they can bring their patients to our our hospitals and our clinics and know that their patients are going to be well taken care of, and where employees want to work, where they know they can show up their true, authentic selves, and feel valued for who they are. And an important part of that involves our focus around becoming a culturally competent healthcare organization, one that acknowledges and recognizes the impact of culture on patient experience and health outcomes, as well as the impact of culture on the delivery of healthcare specifically. I'm talking about the perceptions and established norms of healthcare providers, and also language and cultural barriers, as well as care process barriers, just to name a few. And that's what brings us here tonight. Our commitment as an organization to continue working to make communities healthier, and our promise to serve and care for people in the most appropriate ways possible, being to meet them right where they are, as an intentional way, and as an inclusive way as we can. So again, thank you to all of you for joining us tonight, for what we hope and what we're looking forward to be a really good time of learning and sharing, and using what we learn to implement, and as Dr. Moore said, to take better care of patients and provide for better patient experiences and outcomes. But tonight, it is my pleasure to welcome back to Sovah Health Pamela Bivens Pippins, who has supported Sovah Health diversity, equity, inclusion, and health equity educational programs for several years now. We're very happy to have her here with us tonight. Pamela A. Bivens Pippins currently serves our nation's students, faculty, and universities in science, technology, engineering, and mathematics via servant leadership as principal and founder of A. Bivens Collective LLC. This unique and inclusive collective offers professional services and evidence-based resources from collaborative subject matter experts from across the nation to lead change management on diversity, equity, inclusion, accessibility, and belonging and organizational leadership. To date, her most sustainable contractual collaboration is as the Director of Diversity and STEM Education, funded by the National Nuclear Security Administration, Soft Skills for STEM, or S3STEM, the premier soft skills training and development program founded by one of Pam's former student interns at the U.S. Department of Energy's Los Alamos National Laboratory. To drive change management to a more inclusive culture of belonging, Pam served as the inaugural director for diversity, equity, and inclusion in the People and Culture Department of Howard Hughes Medical Institute in Chevy Chase, Maryland, to create awareness and education on health disparities and inequity and cultural competence and humility. She served as the assistant director for diversity and inclusion at Duke University Health System in the Office for Institutional Equity. She has also served as program administrator at two U.S. Department of Energy National laboratories managing two internship programs for undergraduate and graduate students and faculty participating in state-of-the-art research in the historically Black college and universities and mentored collaborative research programs. Pam received her MA in Education and Human Development with a focus in higher education administration while working at the George Washington University's Graduate School of Education and Human Development. Her BA was earned from the historic Hampton University School of Arts and Letters and Mass Media Arts with a minor in journalism. Please help me welcome Ms. Pamela Bivens Pippins. Take it away, Pam.
Thank you, Leslie. Thank you, Mike. Thank you, Mary, and everyone behind the scenes, making sure everything is prepped and running well for this evening. I want to really make it clear that it's time for you in this hour to center yourselves as healthcare professionals, clinicians, administrators, what have you, to ensure patient safety and quality of care. Now, I do want to make sure, is my presentation on the screen?
Yes, it is.
Okay, just want to be sure. I'm never sure about technology. So I just want to start off by saying again that I love what I do. I hope to continue doing it across the nation and even globally at some point as we learn more about cultural competence in other parts of the world. So my indoctrination to culturally competent healthcare was through health disparities many years ago. and then in patient safety at Duke long before I started presenting PowerPoint presentations and sharing this wonderful, necessary, inclusive understanding of the fact that first, we are all human. We show up human. We take care of humans, or you take care of humans. I am not a clinician. But as a constant patient, I am very concerned about the healthcare I receive and that of everyone, especially those who are marginalized in society based on how we've been socialized. So I do appreciate greatly doing something with you on culturally competent healthcare and also appropriate ways to collect that data. It's really critical to be able to connect and communicate with your patients, as you already well know. So I will get started here. I do want to lay out a few learning objectives. One thing I will add before I do that, there are 2 slides on implicit bias, just to remind us of where all of this comes from, our brains and how we're socialized and how we receive and give information in the world. So with that, we do want to make sure that we understand the principles of culturally competent care. Being able to communicate with patients, their family members, and even your colleagues makes it a really obvious that you care about centering your patient at the time of care. You meet people at their worst times in their lives, most times in the care environment. So please be mindful of culturally competent care and that your patients are human. We know you get burnt out, but we have to be reminded that we are treating human beings and we all have certain ways we like to be treated and communicated with. We also want to make sure that we focus on learning strategies to collect sensitive patient data, which really does inform the care that you're able to give, the kinds of team you put together, the understanding of who your patient is, along with their family member. And we will focus on developing skills to communicate effectively and sensitively with patients from diverse backgrounds. Even if a patient appears to look like you, have your same features, what have you, there are still very huge differences in how they might think about their care and how to receive that care. So we have to be very mindful to center the patient. But in this hour, again, I want you to center yourselves and how you think and feel about the work that you do. Your why for being a healthcare professional, supporting healthcare professionals is really critical. Sometimes our why evolves and we have to be mindful to really interrogate that and investigate that within ourselves. So again, I want to touch on unconscious, or what some say implicit bias. For me, implicit bias is easier than unconscious. I can get tongue-tied. So I will refer to implicit bias as this distorting lens that really is a product of our brains based on how we're socialized, the families we come from, the environments we're raised in, the schools we attend, our religious affiliation, our friend groups, and so much more will inform our socialization within society. And that socialization will shift over your lifetime as you move around to different parts of the United States, or even different parts of Virginia, or within our global community. So we have to be mindful that there's a way that we see the world uniquely and individually with each other. And of course, how we look at various stereotypes and these human characteristics that we feel as though we know who someone is based on the pigment of their skin or the lack of pigment, someone's assumed age or the age that they share with you, the weight of that person. The biases that come with weight in our society are enormous and very harmful. We have to be mindful of that. Accents are different across states, across regions, across the United States as a whole, and of course, globally. Disability, how do we inform disability? Sometimes we can't see the disability because of the neurodiverse brain, that we are not always familiar with someone's differences in how they think, receive information, and how they show up in the world. Height, there's this height thing about, men being tall, they receive more credibility, they are respected more. Gender, we have to think about what gender means to some of us and how we're socialized to think about gender beyond male and female. And there's so much more that we're put into this bias thing. So we have to be very mindful to really focus in and interrogate the way that we think about what bias is from our own socialized lens. For example, if you've traveled outside of the world, you have a different way of thinking about people because you've possibly been aware of or socialized or understand different ways of thinking and how differently people put their assumptions together, how they see you. Now, does anyone have anything they'd like to share about biases or ask any questions before we move on? Because our brains determine how we see other people, how we assume people to be. We have to be very mindful of that. Any thoughts about that, anyone?
It's okay to unmute yourself and give some input or ask a question if you'd like.
Thank you, Leslie. I also saw something on LinkedIn earlier today where someone who's very well known from the Netflix environment and other environments says that biases are the stories we make up about people before we know who they are. Those stories can be very harmful, can skew the way you put treatment plans together with the care team for that patient. And we'll talk more about listening to the patient, centering them during their care stay within the hospital or the emergency room or what have you. So I will move on if there aren't any thoughts, but I'm happy to engage.
One quick comment.
Yes.
This is Pradeep Pradhan.
Yes.
So I think biases also go along with being judgmental.
Yes.
Judgmental because of the skin color, age, weight, and all of those you mentioned, describe beautifully. So we judge people before even have a conversation, before we sit down and chat with them. And that makes so difficult many times being in the patient room, not accepting the person in front of you as they are. We make up the early on. So that's my thoughts.
Well, thank you for sharing. We do have to meet patients where they are. We have to meet the family members where they are. So I really appreciate you saying that. Our biases can harm patients. We have to be very mindful. It can harm our colleagues. So we have to be mindful in that first 1/5 of a second. I don't know how long that is, but that first 1/5 of a second that we see a human being, we're making judgments. We're making assumptions about who they are, which again is very harmful. So please be mindful. So what I'll do is share something else where I just said in 1/5 of a second, our brains work very hard to determine who someone is based on the shape of their face, their nose, their lips, the texture of their hair, the color of their eyes. So be sure you're looking at the screen when I click over here. So I'm asking you, who does your biased brain see? Because all of us have implicit bias. It's a part of our human makeup. Okay, so 1/5 of a second. Who does your biased brain see? Comments? Thoughts? I'll be happy to tell you who they are once you tell me what your assumptions are about who they might be.
If I may say, I saw the beautiful young girl sitting on the stairs
Okay.
on the right.
Perfect. Thank you. Anyone else? Please feel free to share. It's always interesting because we see the same thing, but we see the same thing differently based on our socialization. Yes.
I saw the young lady who is happy, pleasant, open, and other gentleman I saw, again, he did have some construed face, but he's walking. He's determined to get to the goal. So one mind is liberated, other mind is not.
I understand. You that's the look, though. You're right. That's the look. Thank you so much for that. So I will share who they are. So since you spoke about the young lady, she is actually a transgender female. So if she presents in the hospital, there are assumptions you will make automatically that could be harmful to her health outcomes. So be mindful that who you see is not always who you get. But Janet Mock is her name. Again, she's a transgender female from Hawaii. She's mixed Hawaiian and African American. And she chose her name Janet because she liked Janet Jackson. I think she looks a lot like Janet Jackson, actually. Her mother knew that she was in the wrong body when she was a child, and she made every effort to make sure she got the appropriate care that she needed. She had the top surgery. She had her Adam's apple shaven. She's had bottom surgery. Of course, you see her hair that has grown out. So her features are very feminine. She had her nose bridge shaven as well. So she has 2 books that I know of. Again, her name is Janet Mock, and she talks about her evolving life in her books. So if you are so inclined, please take time to check Janet out. The gentleman is Dr. David Troyer. He's a professor. He is from the Ojibwe Nation of the Leech Lake Reservation in northern Minnesota. So most people say when they see him, they see an angry white male. But be mindful, he is Native American. So we have to put our assumptions to the side and really engage in having conversation with people to make sure that you're thinking of them in the right way, that you're going to offer the best treatment plan possible, any other services that are uniquely needed by each patient that you see. So any comments or thoughts about that? Okay, so just be mindful again. We have to be careful about our biases and assumptions when we see people based on how we're socialized in society. Again, Dr. Troyer has written a number of books based on his area of Minnesota, northern Minnesota, The Heartbeat of Wounded Knee, Native Americans from 1890 to the present. And he and his brother wrote a book on Native American fiction. So you can always find him on NPR. And of course, if you do a Google search, his last name is spelled Treuer. Very interesting gentleman. Again, he is a professor. Very interesting. So we shall move on. So again, challenging those assumptions is critical because that's what your brain makes assumptions about when you start thinking about the cultural aspects of your patient, the nuances that are necessary. So this cultural competence in healthcare is critical. We're beginning to learn cultural competence fits in every environment because we have to get to know each other's. Understanding and respecting people's beliefs, values, and histories are critical to the best patient-centered care you can offer. And you also get to learn a lot. This is very humbling work for me because I get to learn so much about so many different topics when I'm asked to speak. But healthcare is one of my bigger concerns because I'm a patient. Every time I show up, I don't know unique nuances about medicine or anything. I have to count on my provider. And this is where culture really steps in and makes a huge difference in how we see each other and how we treat each other, how we talk to each other, and other services that are necessary to make sure you can give the best care possible. So there are 4 principles of culturally competent care. In some instances, there are 7, but I thought we'd stick with the 4. Awareness of your patient's cultural worldview, which means having a really good conversation, asking questions, and allowing patients to give you answers, which sometimes are hard for them to do because they know at that point they will be assumed to be maybe not educated enough or not able to really share the necessary information to tell you who they are based on their own cultural worldview. Awareness toward cultural differences, that means expanding your lens through additional education. I think Culture Vision has returned to the healthcare arena. I know that's one product or platform that Duke does use to help educate clinicians, practitioners, and administrators about varying cultural differences. Knowledge of different cultural practices and worldviews is really critical. We'll show us a slide in a few minutes on the demographics of Danville specifically that's more focused on Black and white, but we have so many different cultures that are practiced around us. And knowledge of cross-cultural skills, being able to cross-communicate. That's one component of the Joint Commission's culturally and linguistically appropriate services to make sure that you can center the patient's language in the care that you're able to give. And I do believe that Sovah Health does have translation services from when I spoke earlier this year. Is that correct, Leslie?
Yes,
Okay,
we
perfect.
absolutely do. Yeah, absolutely.
Perfect. So I'm hoping everyone does take advantage of that, makes no assumptions that a patient can understand. That is really critical to giving the best patient-centered and safe care possible. I did want to throw in the social, or what a lot of people now are calling structural determinants of health, because even as physicians, residents, administrators, understanding a patient's social determinants of health really helps you guide them in the best way possible. And those haven't changed to these 5 that are indicated here: education, access, and quality, healthcare access and quality, neighborhood and built environment, social and community context, and of course, economic stability. So we have to be mindful while we are getting to know our patient, what barriers there are socially or structurally within our healthcare system across the nation. What impedes them? What impacts them counterproductively to be able to seek the best care possible? Please be mindful that this is everyone's responsibility from the moment someone shows up to sign in for their appointment to when they leave, and the medicines that are given, how they will access getting their prescriptions, receiving follow-up care, what have you. It's really critical to focus on these structural determinants of health. Any thoughts about that while we're moving along? Okay, so I will share a quote here that I thought was very insightful about these social determinants of health. They don't look the same for everyone. So we have to be mindful that, we can't put people in a box because they look the same, that they will have all the same challenges with, moving through the care system. And one thing that I thought about earlier today is maternal mortality. I will go backwards for a second because I want you to see that even for Black or African American women, maternal health is pretty critical in this country to the standard of third world medicine. Even for African American or Black women who are highly educated, are very economically stable, have really positive social interactions within their communities, live in very nice neighborhoods and nice homes, and have the best insurance possible, their outcomes are still very, very dire, especially in the maternal mortality space. So that's when I'm saying that the structural determinants of health are not the same for everyone. Even with the best possible outcomes that should present, they typically don't for African American or Black women in this country. So we have to be mindful to be aware I know you always do your research, you engage with each other, you have your early morning sessions and whatnot, but please, there's more to what we have available in this country that really keeps us very well informed. Anyone have any thoughts about that? I know you're thinking and not sharing, so I'm okay with that. I really am okay with that. So I shall move on. So I want to share this YouTube with you that talks specifically about what cultural competence in healthcare is.
Just what is cultural competency? Basically, it means being able to provide effective and respectful healthcare to people of different cultures. A culture refers to the shared beliefs, values, traditions, and ways of life of a group of people. These groups can be made up of individuals who share the same race, ethnicity, religion, or even a trait, such as age, income level, or where they live. Therefore, a culture can be a group such as teens, the elderly, the poor, people who live in rural areas, city dwellers, or the homeless. When it comes to cultural competency, we have to be careful not to stereotype people. For example, just because a person is Muslim doesn't mean she will think or act like every other Muslim. There is a great deal of difference within the Muslim culture. And just because people are from one geographic area of the world doesn't mean they will think and act alike either. For instance, there are more than a dozen countries in the Caribbean region, each with their own cultural identity. So remember, each person is an individual, regardless of where they are from. Becoming culturally competent is not about learning a lot of facts about many different cultures, and it's more than just overcoming a language barrier. Being culturally competent is about being respectful, open-minded, and willing to learn as you go. Understanding how to tailor your interactions to each patient will take a little effort, but look at it this way. The effort you put in now is likely to save you or others even more effort down the road. Why? When you make sure patients receive high quality, culturally sensitive care from the start, you will help prevent patients from coming back sicker at a later time. When people get a lower quality of care than they should, their health can worsen over time. When they return to the healthcare facility, their condition can require more attention and effort to manage. There's another benefit of being open-minded and willing to learn about other cultures that you can experience right away. Being sensitive to other cultures will help make the interactions with your patients go more smoothly, and you will find that you have fewer problem patients. Let's look at an example. This South African woman is in the ER because she's having jaw and arm pain. She has no insurance and explains that she takes a drug for high blood pressure when she can afford it. The nurse remembers that the patient was in the ER a few weeks ago and that her EKG showed non-specific changes and she had a normal chest x-ray. The staff treats the woman with little empathy because of her multiple visits to the ER. The woman senses their indifference and gets angry, which makes the staff label her as a difficult patient. During her long wait, the woman gets angrier and starts being rude to the staff, who can't wait until she leaves. The doctor finally decides to do a cardiac workup, and the cardiac enzyme test shows that she is having a heart attack. She is sent for a coronary angioplasty. How would you feel if you were this woman? Chances are, if she had been treated with respect and empathy from the beginning, she wouldn't have become angry and rude. She also probably would have been triaged as a higher priority, and the doctor would have known sooner that she was having a heart attack.
Any thoughts? Can anyone relate to that in any fashion? Becoming frustrated with the patient because they're being irritable and they're what some hospitals might call a frequent flyer to the emergency room. Some people might consider that drug seeking, or someone who's lonely and just wants to be in the hospital. Anyone have any thoughts?
It's Dr. Moore. I would just say, I think this can really get in your way. That can lead to not only poor patient outcomes, but huge medical legal malpractice risk. One of the most recurring stories I recall from some of my previous experiences were patients coming in with recurrent abdominal pain, CAT scan or whatever was normal. And after 2 or 3 visits like this, the workup got less and less. And in retrospect, the patient had something very unusual, porphyria. And unless you have an awareness for that and you have to listen and talk about urine color and other things, this is a terribly important thing because you just have to have the time to explore this. And unfortunately, FaceTime in medicine has been has become reduced more and more. And yet it is the FaceTime that allows you to talk to people and try your best to get to know them.
Absolutely, Dr. Moore. Definitely. Anyone have any thoughts?
Hi, this is Dr. Scott Spillman. I am the
Yes.
director for Pittsylvania, Danville, and Southside Health Districts with the Virginia Department of Health. Just very briefly, we get a variety of people in all of our different locality health departments, and it's not unusual, in fact, for us to find or to have someone come in who is stressed about their life,
Yes.
and that impacts their health, and their health impacts how they their life and how they interact with people. At the same time, our staff, particularly our the first people they meet are the ones in the clerical, and some of those folks have some of the same stresses.
Yes.
Even though we don't, we do our best, and even with great health insurance. And there are a number of times people come into the health department, either by themselves or with others, and whether they get into arguments and literally fight with each other, we physically fight, or they become extremely confrontational with our front desk and maybe some of the other people.
Sure.
I try to ask the staff to just understand that they, number one, they could just be having a bad day.
Right.
Right. We don't know what their background is or what triggers they've had, either before they got to us or when they walked in the door, and what's their legacy that's made those triggers.
Right.
And to that end, help our staff to the best we can recognize their own triggers, and to have strategies and tactics to how to address this. If we find people that are if we can speak to them, sometimes they'll calm down.
Mhm.
Sometimes they have true mental health illnesses, or sometimes they have other things that we can't quite help, or we just can't do what they're asking us to do. But still, there are times we have successes, and that's one of the things that I find rewarding about this job, is that we're able to step through the biopsychosocial profile of people and look into, maybe not look into their hearts, but look into their, maybe focus on why they're there, focus on what they're asking. Can we do it? And can we talk to them and interact with them in a supportive and like you said, culturally appropriate way? What can we do to help them have an experience that we would like when we go somewhere? And sometimes it's more effective than others, but overall we do have some successes. So, we're not knocking them all out of the park,
Right.
because the people that come in sometimes seriously do have issues that go beyond asking for a birth certificate for somebody, or getting a vaccine, or getting treated for an infection, or getting something else. So it's a complex issue, and we sometimes tend to see people very simply, and if we start looking at them as having more depth and breadth to who they are, I think it helps us. Over.
That's awesome, Scott. Thank you for bringing your heart into the answer and sharing what you've been through. Taking the time to get to know someone and listen is sometimes all that they need. In some cases, they may need to have a prescription filled, and they've been off their meds, and they're just not having a good day, like you said. So we have to be mindful. But this is where our implicit bias steps in. Our fear, that fight or flight mode that we get in when a situation is very uncomfortable and it appears to be escalating. And there just have to be mechanisms and ways to really calm a patient down without calling security or trying to restrain, which makes it worse. So there's so much we have to think about in the moments. And I appreciate everything you shared very much. Very much, Scott. Thank you so much.
Thank you. There's one other thing that, just in a humorous way,
Uh-huh.
I don't know how many people read the book The House of God, and the first rule of the House of God is first take your own pulse.
Okay.
And the thing there is, you cannot help somebody if you're too emotional.
That's it.
And so recognizing that in oneself is critical. So thank you very much.
Absolutely. And you have to know yourself to be able to calm yourself down, to be able to give someone the care that they need, because we have to be mindful that all of us will become patients at any time in our lives, and we would like for someone to treat us respectfully and as a human being. And this just brings up, Scott, thanks to you speaking, brings up where people always say, well, I want to treat people the way I've been treated. Well, we have to be mindful that golden rule does not apply. The platinum rule is more appropriate now, to treat people as they wish to be treated, based on cultural differences, language differences, religious beliefs, in the patient setting, in the healthcare setting. So just be mindful. There's so many complex, as you said, Scott, pieces to this. So thank you so much for putting that out there. So we do have to really be sensitive to people and let them know that we hear them, that we're listening to them, and putting our assumptions away, which is also some of our body language. We can have body language that just shows people that, I really am tired today, and here you come with all of this. And, it's the end of my shift and I'm tired. I have to go pick up my children. I have to do this and that. So it is so very hard and complex to be a warm, caring, empathetic human being at every moment of the day. It's impossible. We're only human. But just being mindful when that situation is needed, it could really help de-escalate and get a patient calmed down, and the family members as well, which can also create a lot of issues. So this is what I was speaking about just a little earlier about the demographics of Danville that I pulled up. Focuses primarily on Black and white patients, even though it shows in, or the population rather, there is like a 1% Asian population in Danville, mixed race at 3%, and Hispanic at 5%. This does appear very recent, 2022, 5 years unless noted. So we have to be mindful of the populations that will show up to receive care from us. Once you get to know the population and understand the needs, especially nuances on religion or cultural beliefs, we can really focus in on the kind of care that we can give our patients and the kind of research it takes for us to be very patient-centered and keeping the environment safe for everyone. And I'm also looking at the population by age range, which can dictate possibly some of the issues you may deal with more frequently, where you're looking at 13% of the population at 20 to 29 years old, and then a further down at 60 to 69. So, just putting that data in perspective really can help you hone in on the cultural nuances that you might need to pay attention to while you're treating your patients, or just how you prepare to deal with anyone in the workplace, along with your colleagues, actually. So there are 6 steps to your patient's culture as far as impacting treatment plans. And we want to go through all of those, but we also want to add in this ethnography piece where you take the ethnography. I know you take the history of the patient, but there's also an ethnography that is really huge that a lot of people are really talking about these days, a mini ethnography, which can help you better understand how identity, interpretation of illness, and the moral values of your patients factor into building that trusted relationship and considering the appropriate care that they need. Has anyone thought of that, or is that something you automatically use, or is it a part of your protocol or checklist, getting that ethnography? Is that kind of a part of the care plan? So it is a piece that really helps you pull in the cultural component of each patient along with their family members. And again, that's something that really helps you focus in on the ethnicity of a patient and the unique cultural issues. So this ethnicity is really important. It's not the same as race. Race is, I'm sure we all know, is a social construct, but ethnicity is more accurate for people telling you exactly who they are and who they aren't based on any assumptions that you might have. So the step 1, of course, how does ethnicity factor into your patient's identity? Again, let patients tell you who they are. Let the family tell you about the patient you're seeing if they're unable to speak for themselves. Ethnicity is really critical because that impacts diet, ways of thinking, believing, how people see themselves, their religious affiliations, which may impact how they're treated. And step 2, thinking about what is at stake for your patient and their loved ones. Illnesses really impact those social determinants of health where people are unable to show up to work. What if they don't have insurance or don't have good insurance? Really impacts how someone will allow you to treat them because they're worried about the cost. How long will I have to stay in the hospital? How much will all of this cost? If I have to have surgery, can it be put off? So think about what all those mean when you really start talking about the care for the patient. Those social determinants of health will come into play, especially if someone's unemployed, So then think about, how does your patient conceptualize their own illness? What are the words they use to tell you what's wrong with them, how they're feeling, as opposed to the words that you're more familiar with as the clinician? Take time to listen to that. For example, I know that when people have diabetes, they'll say, well, my sugar is high. Does that resonate with you as a clinician, knowing the appropriate terminology that should be used? Any thoughts about that? Okay, so we can move on to the other three. What social stresses is your patient experiencing because of their illness? Again, those social or structural determinants of health will create a lot of stressors when you're talking about the financial component, if they're the breadwinner, if they're the only ones working, if they don't have health care, even though they're working, how many jobs are they working to make ends meet? All of that will impact the treatment plan, the follow-up, medications, what have you. And how does the clinical setting influence your relationship with your patient? We have to think about how the clinical setting influences. It may make people uncomfortable. And then you talk about the culture of biomedicine or Western medicine and how that influences your patient's ability to seek and receive treatment for their illness. Sometimes, in blood transfusion for some patients based on religious reasons. We have to be very mindful that that's not always the best answer and looking for alternative means to care for their illness and to let them know that you're listening and they can trust you with their lives, with the outcomes of what their families are dealing with. Really critical as well. And the intervention appropriate for your patient. That will always be a factor when you're thinking, again, no health care or minimal health care or prescriptions covered. Just so many factors that come into all of this really makes a huge difference in how well you get to know your patient, how well you get to know their cultural beliefs and understandings, which is critical to patient care outcomes. And again, like Dr. Moore said, will they return? Because they feel like you believe in them, you trust them, you will give them the best care possible, despite any of the socialized barriers that make people feel very uncomfortable in the healthcare environment. Any thoughts?
It's Dr. Morgan.
Yes.
Just for any of us that are not quite comfortable or sure how to take this history, what are the best questions to ask for to explore ethnicity, do you think?
Well, you can ask a patient where they're from. How has your day been? Sometimes certain questions will trigger people sharing a little more than they'd like to. What language do you best communicate with? And that's when you pull in translation services. And your body language and tone of voice really impacts how they will respond or how they may shut down because they feel, or how rushed you might be talking. But asking questions and maybe sharing a little bit about yourself so that they feel like this is an exchange and not particularly an encounter with someone they don't know, possibly. So be mindful your tone of voice, your body language, and how you ask the question, phrase the question, the words that you use, or just having a conversation and what is gleaned out of that. Have you traveled recently? Where, have you vacationed, or, what they might be doing for the holidays to really bring the tone down in the room and to show them less stress in that, visit where they're uncomfortable and afraid. Because you always should assume that a patient is afraid and there's an opportunity there to create a bond and a relationship there as well. Does that help at all?
Yes. Yes, ma'am. Thanks.
Absolutely. Bring your humanity, bring your heart to the care encounter. That's really what this is all about. It's about bringing yourself in to make sure that the patient is aware that you see them as a human being as well. So this scenario here is very short, but it shows you what can happen in a cultural health case study. So we'll play this one and then we'll chat a bit.
Hello, dear. I'm Dr. Calais. I'm filling in for Dr. Smith. Looks like you had a very successful surgery last month. How's your recovery been?
Well, thank you.
I'd like to begin by doing a quick examination of the location of your surgical wound just to make sure you're healing correctly and everything looks healthy. May I ask you to remove your head covering?
No, I cannot remove my hijab.
Nadira, I want to make sure that you're healing from your surgery correctly, and in order to do that, I need to take a look. Did Dr. Smith not tell you this would be part of the follow-up?
Well, Dr. Smith is a woman, and you are a man. And I cannot remove my hijab in the presence of a man who is not my husband. But that is why I came here, to see Dr. Smith. She can be the only one to do my examination. If Dr. Smith cannot be here today, I will have to reschedule my appointment.
All right. Why don't you wait here a moment, and I will check and see if she's on her way. Elizabeth, I'm glad you're here. This patient of yours is giving me a heck of a lot of trouble. I'm trying to examine the sutures from her surgery, and she won't remove her hijab. How am I supposed to do a post-op checkup with her?
Nadira, I'm sorry. Well, I understand, Michael. It's part of her cultural and religious beliefs that a woman may only remove her hijab in front of her husband. Even if we don't fully understand it, we need to respect those beliefs when treating patients. Well, I better go check on Miss. I'm sorry. What room is she in?
3B?
Thanks. If you want to catch up later and talk more about this, we can do so.
That'd be great. I'll catch you at lunch. Bye.
All right, so you saw what Dr. Callahan's initial approach was with Ms. Nadira Ansari. What are your thoughts to process and prove what happened here?
Let me stimulate some of the. I know we have some of the residents on the call here tonight. So, what do you think the staff person? There was a lady behind the desk at a computer who obviously was very carefully listening, watching what was going on between Dr. Smith and Callahan. What do you think was happening there? What any of the residents want to pop up, or the last motion that Dr. Callahan made as Dr. Smith walked away? Any of our residents want to comment or give a perspective on that? I know you're out there. I don't know. I thought it was very telling. It just brings home the point that as we are in clinical settings, it's like we're on a stage, and so everything we do is seen by others, and particularly as a provider, being at a mid-level or an attending or even a medical student or resident, whatever, we are watched, observed, and it has tremendous impact on all of those around us. And his fleeting motion as Dr. Smith walked away was one that he sort of, it was not a nice thing to do, basically. He basically was sort of blowing her off, if you would, about the whole thing. And you just have to be sensitive to that when you're in clinic settings. Thanks.
Absolutely. Thank you, Dr. Moore.
Not only that, this
Yes.
is Dr. Pradhan. I was looking at the staff, and if there was somebody observing, luckily there was no patient there, and there's an interaction between two physician leader, and how his expression was not understanding, rather rebuking, which is not appropriate in the open setting.
Right.
So that's my thoughts. Thank you.
Absolutely. Thank you as well. Yes, we have to be mindful not to kind of let our body language blow the patient off. Now, in some cases, women expect to be mistreated in the healthcare system. I hate to reveal that, but there's an expectation then when you talk about women from other cultures and she's wearing her hijab, which, we would hope that most people understand is very personal and very necessary in the culture. And I understand why it cannot just simply be removed. And that's information that should have been briefed with Dr. Smith running late or being late and not being able to see Ms. Ansari. So we have to be mindful to do the briefs prior to and then debrief after which Dr. Smith did offer. So
Hey,
there's,
Pam.
yes,
Okay,
absolutely.
there is a comment in the chat.
Okay, yes.
Dr. Spellman said, what type of cultural competency orientation did this physician's staff receive?
Probably none, which is very frustrating. And that's why I mentioned Culture Vision as a platform that I know is used in healthcare systems to teach about varying components of cultural differences around the world with questions you can ask, and answers are provided along with scenarios and different types of learning opportunities. But we have to learn to take advantage of opportunities to learn on our own and what impacts patients in the care setting. Any woman walks in with a scarf, there are assumptions that we make, but those assumptions could be really off base. Various religious beliefs, but a lot of people don't take time to take the different trainings that are available through various, including AAMC, IHI, and various other organizations that I've worked with in the past. HHS offers a lot of that. This is where this clinical piece comes from. So we have to be mindful it's bigger than what our worldview is, what our socialized lens is aware of. And we have to really consider whether or not that patient deserves and to be honored by us and respected by us in the care process. So education is critical.
If I may,
Yes.
say that the ladies, Miss Nadira's doctor, should have made a note somewhere stating that, the patient would prefer a female provider or something of the sort.
Absolutely. Those notes should be in there from the physician who actually treats the patient, so that if they don't show up or they are late or what have you, that there's someone who can step in who is culturally aware. This is how we brief each other. So that is very important to have it in the chart.
Thank you.
Thank you for bringing that up. The notes make a difference. The education outside of strict science research and evidence-based information is really important these days, because we do make assumptions based on our very limited socialized lens. And we have to be aware that people move through the world very differently than each of us, even though appearance may show otherwise. So copious notes are critical. Briefing each other, debriefing, all of that is very important to the centering the patient in the care of what you're able to offer. So thank you for all of your comments. I appreciate that. Again, this is from HHS Office of Minority Health. They have a lot of these videos and YouTubes for learning opportunities. So just to go over it, achieving cultural understanding is being aware. Take time to be aware. We all learn from each other. We call that cultural humility. We have to be aware of backgrounds and that are different in countries other than what we are aware of. The beliefs, the attitudes, the values that we all have are not the same because we're all of the same ethnicity or culture or come from the same part of the world. There will be differences. And think of the word competence. We are never really culturally competent because we're in a space of cultural humility where we're constantly learning. So competence is one of those check the box type things when you're talking about compliance and certifications and whatnot. But we're never particularly culturally competent because we're always in a space of learning and evolving within ourselves. So we combine the cultural awareness with humility, but we want to center the fact that we can be competent across the board and open and aware enough to really want to learn and make sure that we can offer the best care possible. And two, it keeps the hospital out of liability, which is very important. And it keeps you just being comfortable with the fact that you're able to be aware, cross-culturally aware, and offering that patient-centered and safe care, which is critical. So encourage yourself and your colleagues to have that respectful attitude toward individuals from other cultures. It really makes a difference. And for me, I was always taught growing up that travel is your best teacher. So I'm thankful my mother made it a point for us to travel a lot. And since then, I've been traveling a lot on my own. So I'm really learning a lot more about other cultures. And it really makes a difference with your worldview and how you can communicate and interact with patients and their family members. So then we have the electronic medical record, of course, which is a tool across health systems. Collecting that culturally relevant care is data, rather, is very important. Putting it in the chart so your colleagues and your can really be on point if you have to be away to see another patient. Flag those cultural considerations for each other, really critical. And that's again, having conversations with your patient, their family members, or whomever is with them in the healthcare setting. Very important to flag those cultural considerations. Facilitate language and communication needs, again, with translation services. One thing I'm always mindful to share is children should not be allowed to translate in a medical setting because they typically don't have the words or the worldview to be able to share pretty accurately. So be very mindful that children should not be translating for parents who typically don't know the language, the English language, very well. Tailor your health education and instruction. Again, AAMC, Health and Human Services, and so many other healthcare organizations offer a lot of training for CME and CE credits, which is really critical to how you see yourself. You have the self-confidence, the self-awareness to move forward with all the patients and their family members, and sometimes your colleagues. That's really important. Our colleagues are from all over the world. And then promote the cultural competence through continuous education, which I know Dr. Moore and Leslie and Mary are making sure that you have. So you're in a very fortunate environment where all of this education is provided to you. It's just a matter of, I know, having the time, taking the time, and moving forward with learning so much more than you already think, you've already learned to this moment, actually. So this cross-culturally relevant data is really important. Demographic data is critical again. How someone self-identifies to you, not the misunderstanding or the assumptions that you will make based on who they are. Again, culturally and linguistically appropriate services provided by Joint Commission is really important. Enhancing your cross-cultural understanding, and that's talking with each other. From your colleagues from around the world or who travel a lot to other places and have an enhanced worldview to offer that optimal patient-centered and safe care. And then the opportunity to consider the unique differences and needs of each patient individually. We are all uniquely nuanced individuals. And again, we're not a monolith. We think very differently. And most of us take great pride in that because we like to tell someone who we are and what's best for us, which is again, that platinum rule. Give people the treatment that they want, as opposed to how you would want to be treated, is very important. And then in summary, these benefits of culturally competent care, I apologize for repeating myself, but it's all very important. Address disparities experienced by patients of all backgrounds. We all have some sense of disparity, just based on how we show up in the healthcare setting, who may be seeing us, what the health concern could be. Ensure that all patients receive the unique and nuanced care that they specifically need. While you know what's going on in most cases, there are nuances and uniquenesses for each person based on maybe lifestyle, sports, ability to secure medications, what have you. And improve the health equity and diversity. Health equity is giving people what they need, which is not equality. We have to meet each human being where they are and what really benefits them as a unique person. That enhanced patient satisfaction and the health outcomes that you'll find in your climate surveys, your patient surveys, and all the data that you collect to report out to any national organization or the federal government. Building that trust and fostering healthier relationships is critical to patients knowing that you care and they can trust you and they will return time and time again. Increasing, of course, patient safety and engagement is really important because we do also to report out those numbers. And we want people to treat us safely when we end up being the patient. And reduce those care disparities and enrich the patient experience. That's incumbent upon each person individually and also how they walk into the hospital that you so beautifully serve them in, how they feel when they walk in the door, how they know that they will receive the best care possible, how they can engage with you. You're enriching their lives and their experience to show up to you specifically and how they honor you. And with that, I shall stop sharing. I can figure out how to do that. End show.
I thought, Pam, I think Dr. Pradhan had a question.
Please, yes.
So thank you for this excellent presentation.
Oh, you're welcome.
And it's a lot of things have changed, and DEI, I like to call it anti-racism, but then
Yes.
inequity, inclusion. So how do you see, we have come a long way 10 years ago. I've been in practice of medicine for the last 30 years.
Uh-huh.
When I came to town first time, I have a situation when it was difficult to see patients of certain color. They'll just write me off. Okay.
Oh.
And then, but now, established in 30 years, so now I don't have any opening for anybody. So thank God and hard work, and Dr. Moore has been part of that education process. Moving forward with the changing world we live in, how do you see in next administrations coming in, there is a lot of changes happening.
Yes.
How do you see that? I'm like, if you have looking glass to see it, so that we as a physician, clinician, be kind to our patient, meet them as they come to our office, exam room, or when they're at their bedside, so that we can provide quality care in timely basis.
That is a huge question. I thank you for asking that. I will state that I am very concerned as a Black woman in America, the kind of care that I can receive. But you know, the best that you can do individually is show the patient your kindness, bring your heart to the situation, to the encounter, and make sure, again, with your body language and tone of voice, that you insist in letting them know that you care despite any situations, whether it be political, that they're walking into your healthcare environment and they will receive the best patient-centered and safe care possible from you. With you being a seasoned clinician, it makes a difference. You have the confidence to do that. You have the self-awareness to offer that to your patients. And I am 100% plus sure that they will pick up on that and will really appreciate and respect you for that, despite the climate that we are possibly entering into. And medicine is very challenging. Everything has changed. Rules are changing, policies are changing, care requirements are changing, competencies are changing. So it's always ever evolving, because you practice medicine, but you can bring the best person that you are to the healthcare environment. And that's what patients will remember.
Thank you.
You're quite welcome. Thank you for the question. Any final thoughts or anything that you'd like to share with me? Because I'm in a space of learning all the time.
Please, anyone, if this is a time we have someone has their hand raised. Is there another one? Dr. Mitchell?
Hey there. My name's Dr. Larry Mitchell. I'm a family physician.
Mm-hmm.
And I want to say, I appreciate all of your comments. I agree with the importance of them 100%. And you kind of touched on this, but I think that we're entering into a very dark era in all aspects of medical care, and especially those of us that want to have cultural competence to serve our patients. And as you know, concepts such as DEI and quote unquote wokefulness are being demonized by public officials. And I can foresee a time in which people that want to present these ideas, such as you all have, will be censored or excluded from positions of responsibility, or even prosecuted for expressing these views. Do you have any thoughts as to how we as concerned providers can intervene and help this situation? It really worries me a lot.
I definitely agree with you, Dr. Mitchell. I am extremely concerned and fearful for what could possibly come. There will be possible parameters put on this DEI business. A lot of people are focused on using different words. For example, I typically will share dimensions of human difference as opposed to using the word diversity, because it does, and this narrative has been created for us. It's diversity just means human difference. That's really all it is. It's really not a negative, bad word, but it is from the 70s and 80s, and it has been demonized, as you say. But there are different words and phrases we could use. We're always going to be uniquely human and uniquely different, and we will be uniquely culturally different. So there are probably going to be different ways we'll have to craft sharing the information, but it is still needed because you care for human beings. I mean, there's just no way around that. I don't know how else that can be put. But I would hope that AAMC will be able to provide guidance that's not under HHS, that can really share the ways that you can successfully and safely and confidently move forward in the healthcare environment, because it is a huge concern. There are very many people who are very afraid, and your concerns are certainly relevant. And I share those 1,000+%. It's not 100, it's more. But I'm hoping you will receive guidance to really, give that acknowledgement and understanding of how you can move forward, because you're there to care for human beings. That's been your career, that's your training. There have to be bodies and organizations that can share the best way moving forward once everything shifts in ways we think they might.
Yeah. I wonder this.
Mhm.
I would hope maybe you could come back in a year from now, share your experiences, and let us share ours.
Certainly, I'd be happy to.
Dr. Moore, I'm
Dr.
sure.
Moore, we got, we'll be happy.
Yeah, I
We
think that would
typically
be
have her
very
about
helpful.
once a year, so that's not out of the question. Reflecting on these comments, I'm kind of reassured to some extent as a provider, a physician, that basically we just have to show our own abilities and efforts to do the right thing, and that means to be sensitive to diversity and inclusion. And actually, as I was taught in medical school, nothing beats talking to the patient when you don't know what's going on. And I just can't emphasize enough, when there's this overall effort to decrease face time and visits and about volume, clinics, and all that sort of thing, you just have to stop the wheel and spend the time to get to know your patients. And if you were on the previous program, it's that understanding of your patient situation, their cultural background, their needs, their fears. That's how you get patients to have better outcomes, because if you understand them, then you can better work with them in their world, and it's their world that we must work in to make their outcomes better, not our world, so to speak. So these are things that I think each of us can contribute to.
And I guess we all you remember a couple of the points that we made here. We treat people. We don't treat diseases.
Right.
And every person is different. And I think we need to be sensitive. I think that's something we're taught, in family practice residency, and something we should carry with us throughout our careers. But I wish you the very best. What you're doing is very important.
Thank you so much. I appreciate hearing that. You have
Thanks,
no
Doc.
idea.
Do we have other comments or questions for Pam?
Hi, Ms. Pam. This is Dr. Lewis, and I'm here with Dr. Council. We just wanted to thank you so much for sharing tonight. We are working on the GME DI board, and it is heartening to see how much the hospital has been engaging with learning about other cultures and broadening their perspective. Do you have any advice, particularly at the early training level, for ways that we can continue to grow not just our practice, but our knowledge of other cultures?
Well, there are opportunities. There were items we used to do at Duke when I was there. We would have, for example, a culture day where everyone would dress a certain way. They would dress in their culture. They would bring food in. We'd spend maybe a whole half of the afternoon as people could come through and put that together. And then people could tell you about their culture and how they grew up and different things like that. You can read books, you can watch movies and discuss that, have a round table where you can discuss it. We used to have what we call a fish bowl, where we'd have different people in a setting together, just talking as though they were on the couch. And you're learning from that about different ways of thinking and different cultures, people coming from different places in the world, what their worldview is on a specific topic. So it's about, 100% engaging each other and creating that psychologically safe space to make that happen. So people are authentic. Typically, people in the DEI space do want the authenticity because they want to be authentic themselves and they want to share who they are. So just create spaces for that. There are just so many neat, creative ways to do that. You can watch a YouTube and discuss after that, and people can share. Just so many ways where you really don't have to spend much money except for maybe on food and maybe a guest speaker every once in a while to share culturally nuanced information with you. So there are a lot of pieces you can pull together. That's the fun stuff,
This is Dr. Council here. Thank you for those ideas. We'll be looking forward to incorporating that in the rest of the year. Also, thank you for this program. I appreciate especially topics this way where we can kind of learn and grow together. I'm going to look forward to the rest of the year and any other additional programs that you hold. So thanks again.
Perfect. Thank you so much. Again, I appreciate that. I love doing what I do, and I really don't want to stop doing it. I don't think I could. I'm a uniquely nuanced human being myself. So I like to share and talk and engage and just do it all. And Dr. Moore makes sure that I have opportunities to do that, he and Leslie. So I appreciate you.
Any other questions or comments? Otherwise, we're getting to the end of our time. We need to probably begin folding our tent, as it said. Any final comments or questions? Then let me thank Pam for another excellent program. We were talking before we began this, we think is her fourth in her series of DEI programs. She's been good enough to present for us at Sovah Health CME. Thanks to Leslie Sturdivant for her leadership and her help to me and Mary in organizing the DEI series that we will continue next year. We already have programs scheduled for the first quarter of next year. To everyone else on the call, as I remind the residents every time we gather, please be careful out there. It's our privilege to have you participate in Sovah Health CME. It's a great challenge to us. We hope we can help you in your daily work, your daily care of so many patients. If you have suggestions or identify educational needs, please let myself, Mary, or Van Holt know about this, or if you have any issues with the certificates. Otherwise, we all wish you a very happy holiday season. You'll begin hearing Mariah Carey on the radio every 30 minutes, probably very soon on all the Play streaming stations, but we hope it is a nice season for your family. We look forward to seeing you back in early January. We will be sending out notices about those programs. And again, for everyone else, thanks for being here. Have a great evening. Leslie, any final remarks or good to go?
No, actually, I'm texting you all. Thank you so much, Dr. Moore, Mary, Pam, everybody that joined tonight. Those wonderful residents that I'm a little partial to. Thank you also for joining. As Dr. Moore said, happy holidays. I'm going to steal his thunder and, stay safe out there.
Great. And we will, as we say, we'll see you on the flip side. We'll see you next year. Take care. Have a good evening. Good night. Bye-bye.
Take good care. Be safe.
Thanks, everybody.